And I'll call the meeting to order. Noting that I'm just going to do a roll call. Dr. Walls, I heard you're present, but I'm not hearing you.
You're muted.
Probably. Rich Rydell,
Hi, I'm here.
Jerry Nielsen,
Here.
and Kristen Montgomery.
Here.
And we'll ask Dr. Walls to give us a.
I'm here.
Oh, there he goes. Okay, thank you. So all board members are present. With that said, we can move on to public comment period. So it's open for public comment now. I'm not sure how many members of the public we have on the call, but now is your opportunity to make comments to the board.
Oh, Ken, did you want to do the Pledge of Allegiance?
I do want to do the Pledge of Allegiance. Thank you very much for reminding me. We don't somehow get that on the agenda. I would ask that in the future, maybe we can get that on the agenda so I don't skip over it. But yeah, let me do that. So please join me. I pledge allegiance to the flag of the United States of America and to the republic,
And to the republic for which it stands,
one nation, under God, indivisible.
Liberty.
Justice
for all.
That was a little bit challenging because I kept hearing people just lagging just a little bit in that, but nice work. All right, so public comment period.
Ben, this is Jerry.
Jerry,
I just want to make sure that folks know that next week on August 6th from 9 to 12 over at the Veteran, there's going to be a drive-through distribution for Chester Lake Elminor area businesses to receive disposable masks and hand sanitizer for their employees at no cost to them. So just want to make sure that folks are aware of that. And if a business is not able to participate during the time frame offered, then the chamber will be storing the
time frame again, Jerry?
sorry.
What was the time frame again?
It's Thursday, August 6th, 9 a.m. to 12 p.m. at the Memorial Hall.
Thank you. Good news.
And then I also wanted to ask or make a comment that I've had a couple of people come to me concerned because they are seeing some of our staff in holiday and in the post office not wearing masks. And I just wanted to ask that if staff could please try to do that, it would be greatly appreciated because it causes some confusion among people when County Public Health and the state are asking folks to wear masks when they're around other people, and we have our healthcare folks not doing that. So
Thank you for sharing that important stuff. I'm hearing a little bit of reverberation from people, so I'm going to ask that if you're not speaking that you mute your microphone so we don't get the reverberation through our audio system here. Okay. All right. Hearing no other public comment, we'll just move on. Hoping you've had a chance to review the minutes and ask if you have any comments or seen any needed necessary changes. Board members? A thumbs up from Jerry and from Rich. Okay, so not hearing any need for changes, modifications to the minutes from our June 25th meeting. I'd look for a motion to approve those minutes.
I move to approve them.
this is Jerry.
Was that Dr. Walls?
Yes.
Okay, and Jerry seconded?
Yes.
Okay, thank you. Kristen, what's your vote?
Aye.
Aye. Rich, your vote? Rich Rydell?
Hi.
Yeah. Dr. Walls?
Aye.
Jerry? And I vote aye as well, so the motion carries. Next on our agenda is the Med Staff report. We have some items that were approved at the Med Staff meeting on July 14th. These are initial appointments of Med Staff and reappointments of Med Staff. I noticed the first four are all from the telemedicine program. no, not all four, but 3 of the 4. At any rate, I'm wondering if we should take these in 2 parts. Part A, the initial appointments, and I wonder if we can have a motion to approve those as identified on the agenda. Does anyone want to speak to this?
I'll make a motion to approve those under item 1, but I would like to just call your attention to the fact that one of them is a new emergency room physician, and that's Dr. Brink, and he was recruited by Dr. Cooper.
Okay, very good. Thank you. So Dr. Walls has made a motion to approve the initial appointments under item number 1. Can we have a second?
I'll second. This is Kristen.
Kristen, thank you. Okay. And Rich, how do you vote?
Aye.
And Kristen,
Aye.
Gary,
Aye.
and Dr. Walls?
Aye.
And I'll vote aye as well, so that motion carries. That takes us to the reappointment. We have 1, 2, 3, 4, 5, 6 people that need to be reappointed. And are there any comments related to this?
Ken, I don't know, this is Dr. Walls. I don't know if Dr. Ware is here or not, but these are all radiologists that read our films. They're teleradiology. They are already credentialed through the agency for which they work, and then they're re-credentialed through our medical staff.
Okay, and that's all been done, correct?
Yes.
So can we have a motion then to approve these reappointments, A through F on item number 2?
So move.
Dr. Walls makes the
Gary.
motion. Who is the second by? Gary. Okay. Kristen, how do you vote?
Aye.
Rich?
Aye.
Gary? And Dr. Walls?
Aye.
I'll vote aye as well. Okay. Moving right along, that takes us to policies and procedures. We had these policies and procedures were approved at the med staff meeting on July 14th, and we have 27 policies and procedures that were approved. I'm wondering if people have had an opportunity to look at those and if there are any comments or questions related to any of these policies and procedures.
And I wasn't able to get through these, so I'm gonna have to abstain on this one.
Anyone else?
I would just like to say, Ken, that I sit through the medical staff meetings and I have read all of these, and the medical staff, the doctors have all read through these and approved them.
Okay. Any other comments, questions? Okay. Then I'd entertain a motion to approve these policies and procedures as identified on the agenda, numbers 1 through 27.
So moved.
Rich Rydell makes the motion. Can I have a second?
I'll second. This is Kristen.
Kristen. And Dr. Walls, how you vote?
Aye.
Okay. And Kristen
Aye.
and Rich,
Aye.
Gary?
I'm gonna abstain.
Okay. And I will vote aye, so the motion carries as well. Thank you so much. And we are on to item number 8, which is the June financial report. So with that said, Steve, I think you're up. I'm not hearing you, Steve. I don't know if your microphone is on or off. Steve, are you there? Looks like he's stepped away.
Can you hear me now?
Ah, we can hear you
Nope.
now.
Can you hear me now?
Yes.
Okay. TK, are you just going to show the agenda?
No, I can show the report if you like.
That'd be great. I show the attachment is visible now, Steve.
Did we lose Steve? I don't think I see him up here anymore.
Good question. Steve, are you there? I'm not seeing him on our list. PK, I'm wondering if you can find Steve for us. Seem to be having some problems.
Hello?
Hello, Steve?
Yeah. Some of the technology world took over my computer.
Okay. We have their report, financial report
Yep.
visible now.
Okay. All right. So, oh, good Lord. You're okay. Oh, where the heck? Oh, good Lord.
Hit that. Are you trying to sign in?
No, I don't want to.
Oh, just close that.
No. Okay, hang on. Okay. All right. My apologies. Okay, here we go. All right. So for the month of June, we had a net income of $370,000 compared to a budget of $329,000. Again, with the last couple months, there's a lot of things going on in our financial statements. The most significant of which is that we saw a big increase in our revenue from the month of May, where we had $1.3 million in gross patient revenue, and in the month of June, it's jumped up to $1.8 million. Still well below what we had budgeted of just under $2.5 million. But in addition to the $1.8 million in gross patient revenue, our net patient revenue as a percent of that gross revenue was 61.6%, as opposed to a budget of 52.2%. And this is due to two things. One is that even though our revenue's grown, we still are seeing lower emergency department utilization than we normally do. And the emergency department visits as a percent of charges pays much less than our average. And our average is pretty consistent at 52, right around 52%. And for the month of June, it was 61.6. So this offset the negative variance in gross revenue. So our total net patient revenue was negative to budget of $185,000. Everything else kind of fell in line. The expenses overall were positive to budget, $64,000. So our income from operations was just under $240,000 versus a budget of just under loss, that is. $240,000 versus a budget of $109,000, or a negative variance of $131,000. So on page 2 of 7, when we go down into the non-operating revenue, here's where the dynamics begin. That we had budgeted that we were going to receive the payment on an intergovernmental transfer related to the HQAF program. Healthcare Quality Assurance Fee Program. This did not happen. We did receive a direct grant of about $150,000 that's reflected in net patient revenue, but the IGT portion of it did not happen. So we had a negative variance of $400,000. Down at the bottom here, this line 40, as it's done on the grid, non-operating income and expense, this is where we're going to put our CARES Act, our PPP loan money. And for the month of June, we recognized about $535,000 in PPP, triple P loan money. And what that is, there were two full payrolls that we had in the month of June that fell within the eligible period for the triple P loan. And they're running about $235,000 a pay period. We don't get to claim the entire amount of payroll salaries and wages. Anyone that is paid in an annualized amount greater than $100,000, we're limited to the amount of $100,000 that then gets backed into the biweekly payroll period. So basically, 100,000 divided by 26. So that limited the amount a little bit. And then in June, we claimed the health insurance amount. And again, it's only for the qualifying people, those under an annual amount of $100,000. That was about $30,000 and $35,000. And what this leaves us with is the difference between all of that and the $600,000 is the amount that we recognized for lost net patient revenue. Now, to budget, we were negative $185,000, but when we do the recognition of the CARES Act funding, we compare it to what we had last year. And the difference between net patient revenue in June of 2019 versus June 20 was $65,000. So we bring that into income. That gives us the $600,000, and thus our net operating gain or revenue or income was positive to budget 172, and this ultimately led to a positive variance to budget of net income of 41,370 versus 329. Are there any questions about what we're doing there, what that represents?
Steve, can you explain the IGT and why that didn't come in, or is that just coming in later?
I have not been made aware that that program, there's an estimated time frame for that program, what amount that'll be in. That was something we anticipated the beginning of the year, and it just did not happen. They're changing the way they're trying to change the way they're doing it. The methodology for doing it's going to go to what's called a directed payment, and so that's all I really know. I don't have the numbers for this fiscal year for 2021 yet, so we can probably say that HQAF is one of those ones where it's going to start diminishing. I don't know how much that is and whether or not, to what extent it will continue for us.
Okay, other questions, comments?
I just want to thank Steve for providing that detailed explanation of where we're putting funds and taking them from and all of that. So thank you for that, Steve.
Yeah,
You're welcome. And I think what I'll do next time is I will also put in my analysis, because when we go to the whole shebang, if you will, for lack of a better word, because when we go to the balance sheet, and this is a question that Jerry had last time, under other accrued liabilities, we currently have right around $4 million of CARES Act and triple P loan funds that we've already received that are in our bank that we haven't brought into income. The triple P loan will bring the remaining balance of that into income and wipe out the deferred revenue or accrued liability amount in August through the next three pay periods, and the health insurance. But the CARES Act funding and the recognition of that is really contingent upon us continuing to receive or continue to experience lost revenue and a negative impact based upon COVID-19. Now, there's been a lot of discussion about how all these funds should be treated, and even the auditors and even Financial Accounting Standards Board, FASB, who dictates the accounting standards for the CPA and the auditing profession, is not really clear on it either. So we're just doing it based upon this methodology, as this was what the funds were designated for. If we get into a situation where we're not experiencing lost revenue, because for the month of July, we're looking at our gross charges are going to be right around $2.1 million, which will be a decrease from the prior year, but not a huge decrease. And so we may have to go in and start looking at unique expenditures related to COVID that haven't been reimbursed through some other means, and start recognizing income to offset those expenses. So we'll have to see how the guidance is, and ultimately we've asked the question is what happens if things return to normal, whether it's a new normal or the old normal or something, and we have these funds where we really can't demonstrate that we have suffered a negative financial impact. Do we just then bring those all into income, and that's becomes a federal grant? Or that's another thing that hasn't been addressed, because quite frankly, there's very few facilities, probably ourselves, maybe like MODOC up in Alturas, who haven't been hit very hard in relation to historical, and other very small hospitals that haven't really seen a big impact and have received these funds that at least currently are in excess of the impact to them, how that will be treated, and then also how the PPP loan will be treated. Although we've spent the funds in accordance with the rules, we spend them on eligible expenses, we spend them on over an eligible timeline. Someone's just going to have to determine what happens if there's funds remaining at the end of the day. So those are some of the unanswered questions.
Thank you, Steve. Jerry, I have another question for you. The other assets bucket is showing as a negative, and I was curious about what that represents.
Yeah. What we do is when we receive settlements from Medi-Cal and Medicare for prior years, not adjustments to our rates within the current year, we set those in there as kind of a reserve against either the state doing a further review or Medicare coming in and auditing a cost report. So what it is, it's really kind of a deferred income, if you will. Proper placement would probably be in the other liabilities. What we'll do, Jerry, is before the audit for this year, we'll come in and we'll look at all of the amounts that we have sitting on the books for reserves for Medicare and Medi-Cal, and we'll make a estimate of what that should be, adjust it down to that estimate. And then what we'll probably have to do is set up liability accounts for these and get them out of the asset side. So what we call in accounting, it's called like a contra asset. Typically it's an asset account, but since it's a negative balance, it appears that way. And like I said, the proper presentation would be probably over in the liability section. But it's just strictly related to settlements and payments we've actually received on Medi-Cal supplemental payments, cost report reviews, and Medicare cost report settlements that we've decided to defer the recognition of the income because it relates to a prior year. And I try and not run those things through the current year because it distorts our true operations, and it's kind of one of the things I do.
Thank you for that.
Steve, I just want to thank you for staying on top of the CARES Act stuff and how well you've been tracking it for us, and kind of the timely submission of getting us involved with it. So it helps offset some of the challenges we have.
Immensely, and I can't give enough credit to the District Hospital Leadership Forum. We have weekly CFO calls, and these are all the things we discuss. The discussion includes things like CARES Act, but they also bring in their legislative advocates from both the federal and state level to keep us on top of opportunities and what's going on, so that we can send out letters to legislators requesting support for particular pieces of legislation that have benefited us. And so, yeah, that's a great advocacy and peer group.
Oh, glad you're involved then. Thank you so much.
Yeah.
Other comments? Okay, I'd look for a motion then to accept the financial report for last June.
Jerry, I'll make.
All right, move to accept, and can I have a second?
I'll second.
Okay, Dr. Wallace, how do you vote?
Aye.
Okay, and Rich?
Aye.
I'll vote aye. Jerry? And Kristen?
Aye.
Thank you. So we have approved or voted to accept the financial report. That takes us to tab E, the CARES Act Provider Relief Fund. I don't know if this is going to be a bit redundant or not, Steve. I'll let you jump in.
No, this is its own animal. So yesterday afternoon, I sent you all the materials to support this agenda item. Did everybody receive those materials?
Yes, I did.
Okay. Okay. In those materials, and TK, I had to jump off the Zoom because it was taking over my computer and I couldn't get to my documents. So I don't know if you can put up the memo that was in those materials. I don't know if you have that at your disposition.
I don't have those materials.
Okay. Okay. So I sent out a memo that summarized what we're doing here. Seneca was approached by two of our providers that were pretty well convinced that they were going to be financially harmed by COVID-19 issues in their the ability to receive their remuneration from the services that they provided to us. So what we did is we looked at some of the money we've received, and there's a myriad of the funds that we have received, and the first is this. One of the very first things of the CARES Act, the CARES Act, when it first came out, was they put together a $100 billion pot of money, and that was designed to help healthcare providers, from hospitals to nursing homes to individual practitioners, physician practices, to physical therapists, anyone that's a Medicare provider and provides a Medicare allowed service, was targeted for financial relief from the CARES Act. And it was the first round of it was just strictly based upon the amount of Medicare payments you received. And they did a very simple calculation. The payments in fiscal 18-19 were $480 billion. And they took your percent of that and multiplied it by $30 billion, and that was your cut of it. And so the way that Seneca works with its providers, from physical therapy to nurse practitioners to physicians is that they do what's called an assignment of benefits. And so what happens is the providers assign any payments that they would be due for services rendered to a Medicare beneficiary. They assign that payment to Seneca, and we receive the payment, and then we pay the provider based upon the terms of their contract. And some of our providers are based on more or less a salary type arrangement where we say we're going to pay you an annual amount of X for doing this amount of service for us. Some of the other providers are paid on an hourly basis, such as the emergency room physicians. And then others are paid on what's called an RVU basis, a relative value unit basis. And this is really just a production-based reimbursement. Our physical therapist is paid based upon the revenue he generates for us, and then some calculations are made to come down to a net payment to us. So the providers, the physicians that are paid on an RVU basis, and the physical therapist that's paid based upon charges to the facility have the potential to be impacted by changes in the utilization of the hospital. Normally, that's what they say is a rub of the grin, if you will. You know, our utilization goes up and down, but in the case of COVID-19, which again is something we really haven't seen, it impacted them in really an inequitable way, specifically or especially when the governor, California, ordered hospitals to stop elective procedures, non-emergent procedures, and which basically shut down surgeries. And so our general surgeon, Dr. Jensen, was greatly impacted by that. So what we did is we went in and we looked at this thing from two perspectives. That one, we looked at can we even do this? Is it allowable? Because there's numerous things to prevent inequitable, if you will, transactions between a hospital and physicians and providers that have the ability to refer patients to the hospitals and thus generate revenues. Two main pieces of legislation that govern this is Stark, which covers physicians, and then the anti-kickback provision. And so we had to first find out, is this something we can even do? And one of the documents that was sent to you is the analysis from the attorneys we engaged to look at this. And in their document, they go through a lot of things, but mainly what they say is safe harbors, if you will, were generated to provide for reimbursement to physicians that were harmed by COVID so that they wouldn't run afoul of Stark or anti-kickback. And basically what Stark and anti-kickback says two things. One says you can't pay for referrals. You can't give them money to steer business to your hospital. And two, that there needs to be an arm's length fair market value relationship between transactions between a hospital and physicians, so that we're paying them for fair market value of their services. Because if we're paying them for more than the value of the services provided, the inference there, or the first question is why, and the inference there is that you're indirectly paying them to refer patients to the hospital, and you have to defend why. Now, in some cases, we can defend saying that getting surgeons, orthopedic surgeons, specialists, whatever, to Chester, California is a challenge, and we have to pay a premium, and that you have to cover in showing how you came to it. But so we just wanted to make sure that we could cover ourselves with this. And the bottom line from the attorneys was, yes, what we're attempting to do here is allowable, provided that we put it forth to all physicians, come up with a standard methodology, and then memorialize it in an amendment to their existing contract. So pursuant to this, we looked at some of the CARES funding, and that whole first round of the CARES Act, we received three individual payments, three separate payments that totaled just over $560,000. Then critical access hospitals were reimbursed 2.84% of their actual cost from their fiscal 18-19 cost report, and we received that in a lump sum payment, and that totaled $476,500 odd. So we said that, one, the first round of payments, the physicians would have received this money had they been freestanding. Had they been on their own, hadn't assigned their benefits, they would have received some remuneration from the CARES Act based upon the amount of charges they had in the prior year. So we did not go the route of saying, here's your charges from the prior year. What we did is we said, we're going to take this pot of money and we're going to say, how much lost revenue did you have? We didn't feel that we had an obligation to follow the methodology of how the fund or the pool of money was created. We said that this money is being provided, or the consideration is being done to replace lost revenue for these physicians because of direct COVID impact. So we did that for all of the physicians, and we did that by comparing their utilization, the revenue that they generated from the period March through June of 2019 versus March through June of 2020. We did this for the physical therapy and the clinic providers. Dr. Jensen was able to do his normal load of surgeries in the month of March, and so he had no impact in the month of March, and so we ran him from April to June. So when we calculated this methodology, we saw an impact to both Dr. Jensen, and we saw an impact to Lake Almanor Physical Therapy. We saw an impact to an additional clinic physician, but as noted in the narrative, this physician voluntarily closed their practice during this time and used the time while the practice was closed, did see some patients, but used the majority of the time to do administrative functions of chart completion. We did not feel that paying for administrative functions was in the spirit of what we were trying to accomplish here. One other primary care physician that's on an RVU basis did not experience a financial impact. The three providers in the clinic, 2 nurse practitioners and 1 physician, were not paid on an RVU basis, and were paid primarily on what I talked about, that salary annual compensation basis, and didn't, in our assessment, did not receive a negative financial impact. So there was no proposed payment to them. And then we looked at the ER physicians, contract ER physicians who receive RVU payments when they provide certain hospital services, observation and inpatient. And it was pretty much impossible to compare timeframes because unlike a primary care elective type environment that's a little more consistent, a little more predictable, the observation and inpatient is pretty much contingent upon the patient having the need to meet having the medical need to meet those criteria. Although our overall volume in those areas are down, we just couldn't come up with a basis to compare the periods and assess the financial impact. So we said we couldn't determine a negative financial impact and propose no payments there. So that's what we've done here. Are there any questions or is there any discussion about what we've done and how we've gotten to this point?
Board members? Jerry, I see your lips moving, but I'm not hearing you.
They said it all makes sense to me. But
Anyone else?
Okay.
All right, Steve, I'm assuming this is just informational. There's no action required here.
Yeah, there's action required. We are requesting action. We are requesting two things. One is we want you to affirm what we've done here and direct us to go forward with finalizing. We've given you a draft of the proposed language of the amendment to the contracts. We want your approval to move forward with finalizing those agreements with each of the providers. We need to have this in place should we get another wave of COVID or anything like that. We'd want to do this again, or we want to consider the ability to do it again. And if something else comes up, if there's some, Lassen Peak goes off, if there's something that we have what do they call it? Public health emergency, where federal or state funds become available to subsidize our operations that are impacted by a public health or other emergency. We want to be able to do this in the future. The other thing is we've actually calculated a benefit for two of the providers, or an estimated reimbursement that we put in the packet. We're asking for a payment of $43,093.61 to Dr. Steen Jensen and $52,027.51 to Almanor Physical Therapy.
Steve, can you repeat the amounts, please?
Yeah, the amount for Dr. Steen Jensen is $43,093.61, 43093.61, and for Almanor Physical Therapy is $52,027.51, 5207.51. All the funds to pay this will come out of that deferred revenue, the $4 million of deferred revenue that we talked about. We'll go ahead and pull the total, the just over 95,000, pull it out of deferred revenue, bring it into income, put it into our unrestricted bank account, and then make the payment.
Hey, Steve, I have a question. This is Jerry. Even though we're not, we didn't find any undue impact to our providers that are on RVU system, wouldn't we want to make the same amendment to theirs in case we have further issues with being able to bring patients in?
Yeah, absolutely. It'll be incorporated because we've gone to a a template contract for physicians and other providers, and it'll just be added to all of the existing ones and any future ones.
That's why I was asking, because the ones that we were given were specifically for those two providers.
Yes, we have to do that.
Okay, other comments, questions?
Ken, could I just make a comment?
Yes, please.
I would personally request to not be included in any of this, and I would strongly endorse the methodology that's been used to arrive at these numbers. But as far as voting on it, I'm going to abstain.
Thank you. Anyone else? All right. So Steve, correct me if I'm wrong. We are looking.
I have a question, Ken.
Rich, go ahead.
Was Dr. Ware made aware of this?
Yes, at your suggestion, Rich, we sent a an individual or personalized, however you want to call it, to every one of the providers that were potentially impacted with a detailed analysis. I did not provide the individual detail for any of the providers in this forum, just the summary for Jensen and Almanor Physical Therapy, but each one of them got their own analysis and an explanation of whether or not we felt they were impacted financially in our decision to not make any payment at this time, and made the offer to sit down with them and go over it in person or otherwise.
Good, thank you.
Okay, as I understand this, and Steve, correct me if I'm wrong, we're looking for a couple motions here. One would be to affirm the methodology for provider relief funds. And then 2, to approve the funding amounts for Dr. Jensen and Lake Almanor Physical Therapy.
And also the contract modification.
Yep.
Right.
And would that be included in that, the contract modification with the dollar amount?
Not necessarily. I think there's 3 things. I think the first 2 things you said were perfectly stated, and then I would make the third statement, or the third item, to say approve and direct administration to incorporate the amendment, the proposed amendment, into all provider contracts, current and future.
What amendment, what kind of amendment? Can we label that somehow?
What did we call it?
Let's see.
There's a document, and right now they're calling it Amendment to Primary Care Physician Services Agreement.
Okay. All right, we're gonna have a little technical language here. We'll give it a shot. So I'm looking for a motion, 1, to affirm the methodology for provider relief funds, use of provider relief funds. Can I have a motion on that?
Jerry, so moved.
Karen Nielsen moves. And a second?
I'll second.
15 seconds. And so we'll now vote. Rich, how do you vote?
Aye.
Rich votes aye. Dr. Walls?
I'm going to abstain.
Same. And Kristen?
Aye.
Jerry? And I will vote aye, so that motion carries. The second motion would be second vote would be to approve funds, relief funds for Dr. Jensen and Lake Almanor Clinic for Dr. Jensen in the amount of, I'm going to need a little help here. Hang on a second. I'll make sure I get this right. $43,093.61. And for Lake Almanor Clinic, $52,027.51. Hope I got the numbers right, Steve?
It's actually, isn't it for physical therapy, Steve?
Yeah. Yes.
Lake Almanor Physical Therapy. Thank you. So can we have a motion on that one?
Yeah, Ken, just real quick, Renee, for the motion in the minutes, it will be Almanor Physical Therapy.
Almanor Physical Therapy. Okay.
Yeah.
Thank you. And I got the amounts right then, Steve?
Will you please say them one more time? Sorry.
For Dr. Jensen, $43,093.61.
Oh my gosh, sorry. I am 43,000. Okay, let me just say it this way: 43093.61.
Okay, that's what I had. And for Almanor Physical Therapy, 52027.51.
Perfect.
All right. Can I have a motion then to approve the use of these funds and those amounts to Dr. Jensen and Almanor Physical Therapy Clinic.
So moved.
I
Second.
second.
Okay, Jerry Nielsen makes the motion, seconded by Rich.
Kristen.
Yeah.
Okay. Kristen, how do you vote?
Aye.
Dr. Walls?
Abstain.
You? Rich?
Aye.
Gary? Gary, I didn't hear you.
Aye.
Thank you. And I will vote aye as well. That motion carries. And the last motion is to amend the contracts for all providers. Steve, you're going to have to help me out here to incorporate the proposed amendments. I need a little help
Yeah.
with working on this one. Proposed
Yeah.
amendments to all provider care service contracts.
Yeah.
Service agreement. Service agreement.
Yeah, incorporate the proposed amendment to the primary care services agreement into all existing and future provider contracts.
Okay, so having heard that, has someone captured that on your end, Steve?
When you say captured, can you
Well, just
define that? Or,
you have that written down so we can mirror that language exactly.
yeah, I think Renee's on the phone and she's writing it down, but I'll write it down as well.
And I'm not quite sure how to do this because I can't repeat that. Maybe someone else can, but I'm looking for a motion that incorporates the language that was just mentioned by Steve to modify the care contracts for providers.
I'll make a motion to amend all current and future physician providers or service contracts with the language provided to us today that relates to adding section 6.3.6 COVID-19 reimbursement, et cetera.
Right? Can I have a second for that?
I'll second.
Okay.
Good job, Jerry.
Thank you, Kristen. Okay, and let's take a vote. Rich?
Wait, discussion here.
Okay.
I'm looking at these recitals. The recitals are pretty specific to the COVID-19 and the CARES Act. Is that what we're going to do? Amend everything to this specific, very limited CARES Act and COVID-19?
Steve, can you respond to that?
Not very well. Yeah, I see what he's saying. So what I'm going to do is we can keep it at this, and what I'll do, and this will allow us to address this. What I'll do is I'll talk to him about that, how we make provisions for future things. So this will be specific to COVID-19.
Which is very limited and probably won't impact them very much anymore.
Well, because we had the discussion with them about allowing for supplemental reimbursement based upon unique or unanticipated events. And so that's kind of where we were going with the discussion. But so not to hold this up, let's just do this. And when I wrap this all up, I'll ask them to take this same approach and see if they can propose language that would allow for future similar, but the reference to public health emergencies and things like that. So,
Yes.
okay, I appreciate that feedback.
So Jerry, would you care to amend the motion then?
Oh, I'm not sure we need to amend it. I'm just
Uh-uh.
pointing
No.
out that, we
We're
ought to
just creating a limitation on what we can do, that's all.
Yeah.
That's fine.
Okay. Let's go with that then. No further discussion? Okay. Rich? How do you
Aye.
vote? Aye. Dr. Walls?
I'll abstain.
You. And Kristen
Aye.
and Jerry? Jerry? Okay. And I vote aye as well. Having a little trouble hearing you, Jerry, the first time around, but I could see, I read your lips. So, all right. All right. Thank you, Steve. A lot of work.
All right.
Moving on to the HRG report.
Okay, so I really don't want to spend a lot of time here on the report itself. We're working through our issues is the best I can say on this. Now, the way we set up our calculation of AR days, it's meant to consider and account for swings up and swings down in revenue by picking a period of time to get your average daily revenue. But the swings we've seen from going to 1.3 million, down to 1.3 million in May to up to 1.8 million in June, it does have an impact on the calculation. I went back and I took the 6-month average, and it brought this down. It brought this down almost 5 days. So it's still not good, but it's not as bad as it looks. And there's bigger things at work here. And if you look at as we talked about in the treasurer's meeting, that the way that they're presenting the information, you just can't hide from it anymore. It all jumps right out at you, and they have to address it. Now, in the month of June, there were a couple other things. Every June 15th or so, Medi-Cal runs out of money or they stop making payments, so they've held claims for 15 days. So we weren't paid for that, and that does affect the numbers. And we're still struggling with one of our Medi-Cal managed care payers, their own issues. So, it's not as bad as it looks. So we just think we're working together with them now, and we're getting a sense that we will be making progress. But I'd like to talk about progress in the next agenda item. And we can hold them to it. So our unbilled also went up a little bit. That's where we either have patients in-house that haven't been discharged, or we've discharged a patient, but we haven't done everything we need to do to get the account ready to bill. And so that's kind of on us, or all on us. So that's one that we have to work on to support them, and that cost them a couple days. So kind of it is what it is. We've seen some better numbers. We've seen some better things happening in July. So we are seeing some of that progress. But more importantly, yesterday I had a second discussion with HRG about their the contract renewal. And they have put forth a pretty good contract proposal. They're going to have 10 measures that are going to be met, not met, that support getting us to the number we want, the best practice number of 45 or whatever it is. And each one of those numbers comes with a incentive or disincentive or penalty of 1%. If Seneca meets their unbilled target, so if we hit our target of what the unbilled days are supposed to be, it doubles, it potentially doubles the penalty. So if they're not hitting their target, they get hit for 1%. If we're hitting our target, it goes to 2%. So theoretically, their penalty could be as much as 20% of their fees to us, which run around $40,000. So that's skin in the game from my perspective. That's 2% would be $8,000 a month times 12 months is almost $100,000. So in addition to this incentive, disincentive, and I'll be frank, I haven't looked at the incentive as closely as I looked at the disincentive, because we're so far away from it. but I'd be more than happy to pay them 10% more if they hit best practices. So the other thing that they've offered up is, I think one of the issues with us being able to bill as efficiently and effectively as possible is our clearinghouse company, which is the entity that we send the claims through prior to sending them on electronically or sending them on otherwise. And they get scrubbed for compliance with coding and other factors. When it's a true electronic claim submission, it also scrubs it. It communicates with the payer, and if the payer rejects it, it comes back to us, and we're able to deal with it right away, as opposed to if we have to mail it in and wait for a paper denial or formal denial, physical denial. They think there's a company they work with that they are really comfortable with and have had good success with, and they're proposing to offer that service to us free as part of the contract. Currently, we pay around $3,000 for the clearinghouse, and that's about similar what we would pay if we paid for this service through HRG. So there's another $36,000 savings to us. So those two things together, I think, represent a great contract proposal. So, of course, they're going to want something back. The thing they want back is they want a 2-year contract. And right now, with our numbers being, the 90-day, 3-month, 6-month average daily revenue aside, we've seen our AR days go from 62 in April to 66 in May to 73 in June. That's not a trend that inspires me to sign a 2-year agreement. So what I told them, or we discussed yesterday, is I have to see July's numbers first. If we have some improvement in July, move in the right direction, and I can see from what they're doing on the things that where we're still not meeting our target, and I'm comfortable with that, I think I would be willing to support pushing a contract to you all for your approval. If July doesn't give that sense of comfort or that level of comfort, we have to wait another month, and we'll just continue on our month-to-month arrangement.
Steve, this is Jerry.
Yep.
Could we consider giving them a 2-year contract, but having a cancellation clause in there that has to do with performance, so that way we can get out of the 2-year contract if they continue to.
Yeah, there's an out clause in it, and it exists. It's doing the conversion to this Quadrex is gonna be a time commitment on both of our parts, and so sure, we can get out of a bad deal, but do we want to push more chips in with them before we fold, or whatever the analogy should be here on that one? I don't know, but it's in there if they don't meet it, and I'll also make sure that the out for cause is tied directly to the performance.
Yeah, no, I guess my confusion is, so if we use this other clearinghouse, but then we decide not to use HRG, can we still use that other clearinghouse?
Yeah, we just have to pay for it.
Do we know if that's about what we're paying for the one we have now?
Yeah, it would. Yeah, there would be probably no financial difference from what we're doing now versus what we'd have to do without the subsidy from HRG. So that part's low risk.
It's going to make sense to wait a month.
But we are taking a leap of faith with this company.
Fair enough.
And at the treasurers meeting, there was a request to talk to some current HRG clients, and we did get 2 references. One is Modoc up in Alturas, and the other one is Southern Humboldt over in Somethingville, up in Humboldt County, California. And I know MODOC has a nursing home, so, or I think they do. So anyway, short report or short comment is that we have a good structure of a good contract. The out clause we'll look at in place or proposal, and we're really waiting to see July's numbers.
Okay, but I like what Jerry had to say, but Steve, what's the difference between a 1 year and a 2 year contract as far as we're concerned?
I guess if the out's in there, then probably none, Rich.
Yeah.
I'll have to look at.
So give in to them. Give them something. The 2 year contract doesn't seem to be any risk on our part
Well, Rich,
as long as we
Okay.
have an out.
Rich, I
Okay.
think he was saying though is that if we do that and move forward, then we change to this other clearinghouse, and then maybe things still aren't working with HRG. We put all that work into changing to a new clearinghouse. Do we want to do that?
Yeah, well, if we change to new, another clearinghouse, I mean, that doesn't affect the 1 year or 2 year, right? We'd have the same problem with either one.
I think it just adds work that if we were to decide not to do a contract with HRG and go with someone else, that we wouldn't have had to do that work.
I get that, but if that doesn't have any impact on whether the contract, if we contract with them, whether it's 1 year or 2 year, right? I mean,
I think he's just waiting to see timing wise. So if we start to see improvement, then we say, yeah, let's jump forward and do this. But if we don't see improvement, then maybe we're actually looking for another company to work with.
Yeah, and we
Oh, no, I'm not-
actually have.
I'm not
Yeah.
suggesting we move, we don't move forward now. I'm wait for Steve to tell us whether he's comfortable with it and
Got
then
it.
go for a 2 year contract.
Yeah, that makes sense.
All right, other comments, questions? I apologize in advance if my dog starts barking. I'm home alone and I can't tell him to be quiet, so. At any rate, any other comments, questions related to the HRG report as well as the contract discussion? Nothing? Okay, well, Steve, thank you.
Thank you, Steve.
Okay.
We're moving on to item 11, which is our committee reports. Strategic Planning Committee. Anything?
I just have a couple things real quick. The Collins Land Purchase Agreement is, I mean, we've beat it to death. It's sitting with Collins right now, so I anticipate having it at next month with none of this back and forth anymore. I think we're done with the back and forth. So that's what we're thinking. One thing I wanted to bring forward is with the legislature in Sacramento dealing really with the whole financial crisis of COVID, you know, not just for hospitals, but at the healthcare, but at the state and local government and what's going on there. The legislative process has taken on a whole different trajectory, I guess, if you will. But one of the things that's actually been really positive for us is Senate Bill 758, which is the seismic bill, where we were pushing really hard to get some relief, mainly in the area of the amount of square footage that would have to be meet the highest standard to just the emergency department and possibly reduce our cost of construction in half, is still there. But there's also been a big push lately that they're now incorporating a part or an amendment or addition to it where they're going to try and push the seismic standard out from 2030 to 2037. And there appears to be a great deal of support for some extension of the deadline. It appears that there will probably be a compromise there, and just the number being bounced around now is 2034. So this is going to be a big big game changer for us, because now we're looking out 14 years, and with a construction timeline of five or so years, from start to finish. Now we're looking at, there's a possibility we could be in our existing facility for up to 9 years. So now we need to, when the strategic planning reconvenes and gets serious about what's before them, I think the idea of doing something on an interim basis, in other words, to the existing facility, not retrofitting it, but making the existing facility more usable for that potentially 9-year period versus just going forward with construction. Because the other thing, again, that's not clear, that we've talked about before, is what is the credit market going to look like? Are people going to even be able to borrow money? If you're not paying cash, what's it going to look like to go out and seek $20 to $40 to $50 million? And that's going to put a lot of projects on hold. People with existing debt now, their credit ratings are going to take a hit. They're going to start violating their bond covenants, and so it's just going to turn the credit market upside down. And so we have no sense at all of right now with our ability to go out and seek funds if we even wanted to move forward. So the possibility of moving this deadline out is huge for us. So stay tuned on that one. And this, we could know soon. This one's in the Assembly Health Committee right now. If it gets by there, it'll go to the Assembly floor. The current session is scheduled to end August 31st, so this could possibly be voted on by the end of next month, and we know exactly what we're looking at. So stay tuned there, I guess. That's all I have on Strategic Planning Committee.
Yeah. Questions? Anyone? Good to know, Steve. Thank you.
That was good information, or good news.
Okay, the search committee, Jerry, Kristen, anything here?
I will discuss that, I think, during our close.
Okay. All right. Steve, that just put you right back on page here with us. Administrator report, acting administrator report.
All right. So the report that went to you is in the standard, or the format for the last couple of months. Everything's kind of the same. The only thing that we've seen differently is since we last talked, we finally have seen we've seen active COVID cases come into the hospital and be treated in the hospital, ultimately sent to other locations, whether it was discharged to home for quarantine or discharged to an appropriate level of care. So that's the real difference in our environment. And of course, those of you that are following things, just Plumas County in general and the Lake Almanor area have seen an uptick in cases. And just this week, we've had almost each day, I think we've had an additional case. And the biggest thing about this is, at least from our perspective, is when we first started seeing cases in the basin, positive cases, we hadn't had anything to that point, and so it got our attention, as they say. But what was really been surprising to us is that even though there's been additional cases, we've not experienced a spread, at least to our knowledge. A spread that's hit either Seneca or has hit somewhere where someone has been tested that Plumas County has been made aware of. And so if there's anything encouraging from this, at first our area saw a resistance to the virus itself, and at least what we've experienced lately, and knock on wood, we've seen a resistance to spread, which is super encouraging, important, and all the above, as we see the population grow in our area and we see the mass gatherings in just the natural mass gatherings in our area, from whether it's outside restaurants or supermarket or just places around the lake, the golf courses, wherever it might be. We just have more people in one place that we didn't have when COVID first started. So, fingers and toes still crossed, but that's really been an encouraging, and our ability to respond to this, continue to respond to this is also an encouraging thing. So the other piece that's different is that in the projections that I did for you guys, is that we're still working off the projections that are in your board packet are now for July through December, and they're based upon August numbers, financial numbers with some, as I know, minor modifications. But our revenue in the month of did I say August? April of 2020, our gross revenue that month was 1.4 million. We hit 1.8 million in June, and as I mentioned earlier, we're looking at somewhere between 2 million and 2.1 million in gross revenue for July as we sit right now. So we're well exceeding the revenue and then in turn the net revenue that's in our projection that we have for July to December. Likewise, our expenses are running lower than April, but I think we're going to start seeing some of those expenses come up in relation to May and June, in that now we have Jensen coming back and our outpatient numbers are starting to rise. So and these increases in revenue are really strictly outpatient. We still have very limited, very low inpatient volume, swing bed. The nursing home, we're now down to 11 residents. We're being very, very, very cautious and conservative about taking in residents because, in addition to just the general concerns for the residents and the employees and everyone that's down there, is that now the state is telling us that a transfer to a skilled nursing facility needs to quarantine for 14 days. And it's like, where can they quarantine for 14 days or isolate? So we're looking at what we might be able to do with that, and that just puts a further restriction or limitation on our ability to fill beds. But I think it's good too, because one of the nice things about having the lower census is the residents got back their dining room, their activity room. We were using that as a room for the residents when we were full, because we pulled them off the acute wing. And then now, as we're doing the remodel on the patio out there, they've lost their patio. So it's been a tough go for them. So any relief they can get is welcome and really something we want to do. So I guess the short story there is that these projections are extremely conservative, and like I said, they based upon everything staying the same as far as the level of virus that we experience here. We should be on okay financial footing when we get through December. And are there any questions about that? Any of that? Or discussion?
Questions?
I just wanted to ask if you might talk about the drive-through testing that's going to be happening next week.
Yeah. So in conjunction with the county, we've gone ahead and set up so that the first Tuesday of each month, we do a drive-through testing that's completely free to the public we're taking some of our COVID funds. We did receive some funding to support testing, and we're paying for the cost of the reference lab, whether it be LabCorp or we send it to Plumas District when they have the ability to support this. And we'll pay for that cost, and we'll use our staff. The county will register the people and do all the registering and scheduling, but we'll do the swabbing and then do the send out. And like I said, we'll continue to do this. We're limiting it to 50 people, and that's what we have for that. We also did 2 focused or exposure mass testing in this month when we had the initial outbreak in our area, where we tested, can't remember what my number was, I put it in the report, but we set it up for 50 each days, and we had very close to that both days. This one, since it was a suspected COVID exposure, we went ahead and we can bill insurance for this. So if people had to have insurance. If they didn't have insurance, there would be a charge for $40, which we would then work with. If the patient didn't have it, we'd see why they don't have insurance, if we can get them Medi-Cal, or if we can qualify them for charity care.
Steve, what's the turnaround time for the test results?
Kind of all over the place. Certainly seems like it's not less than 5 days through LabCorp. It's gone as high as 10 days, but I think we received all of the testing back when we did the exposure testing within 5 days. But it makes it difficult because, you know, we'd like to give an estimate. We'd also like to have responsive results, but we have no control over that. If Plumas District Hospital has their testing up and running, which last time we discussed this, they did not. They did not have the supplies they needed. They can turn around it in 24 to 48 hours. And as Ken, you and I talked, otherwise that's only Monday through Thursday. It's not on the weekend.
Steve, what about the status of when we might take delivery of the lab equipment that we need to do that?
That's what I was going to ask. Perfect.
Our own lab equipment? Is that what you asked about?
Yes.
Okay. I'll fumble through this one, and maybe Karen Turner, if she's on the phone, can come in and save me. But we have the ability to do antigen testing now, which is not the PCR testing. The PCR is the Bible. I mean, don't get Dave Monday going, but the antigen testing the reliability is improving. The problem is that a positive antigen is pretty much positive. There's no debate there. A negative antigen, state public health, county public health, they want us to send it on to do a PCR testing as well. So Dave seems to think that the accuracy on negative antigen testing is improving greatly, and he's kind of resisting. I think he's absolutely resisting sending a positive on for future testing. He's just embracing that. The negative, he says, okay, I'll do that for now. So that's kind of where we're at on what we have internally. Karen, if you're on, you want to add anything to that or correct me or?
Yeah, can you guys hear me?
Yes.
Yeah, that was correct. The positives are 99.9% accurate. The negatives were in the 80s, and now they're about 96 point, I think he said 6% accurate when they come back negative. And the CDPH was making us send them off for the PCR testing, but it's been proven in the last 2 to 3 weeks that they're coming back absolutely accurate.
But Steve, what about the equipment that we had ordered? I think maybe that's what I was asking.
That's the one we do the antigen testing on.
Okay. So we've received everything that we ordered, the equipment?
We have what we need, but what the problem is now, the company that we have contracted with for the supplies are only allowing us to do certain things. That's frontline workers, healthcare workers, inpatients. There's only certain things we can do to get our our supplies reimbursed.
Yeah, Karen, thank you for that. I think what Kristen is asking is a few months back, we approved a contract to purchase some equipment that was going to test for influenza.
The one that does the 27 assays, the 25 assays, yeah. That's supposed to be here around September, I believe.
Yeah, I think that was the question. Thank you.
Yeah. Sorry, Kristen.
Yeah, so that explains, I guess, the 5-day turnaround times, because we're not able to do all the testing ourselves because we don't have the supplies that we need.
Correct.
Additional questions, comments?
Okay, I have a couple more things real quick. Did Royce, did you make it on the call?
Looks like he's there.
*6. Okay, I'll start.
Can you hear me
Hello?
now?
Perfect.
Can you hear me now? Okay.
Yes.
Yeah, very, very well. Okay, so I'm going to preamble this and then turn it over to you, Royce. So at the Med staff meeting, we talked again about some of the challenges we have with getting ambulance transport, and specifically Chester Fire. We believe Dr. Mellon had a discussion with some representatives of Chester Fire, and they said that they feel they have staffing, but it's a matter of it's a financial thing as far as paying the guys enough to come off a call or come in on a call or to make a run where they lose money. And so we told medical staff that we would go ahead and talk to Chester Fire, because we have the luxury of our ER manager is on Public Utility Board. So we talked to Royce about this, and we asked Royce to give you guys a brief update where he thinks this all stands.
Okay. Thanks for having me. So I was able to speak with Brian Lane, who is the fire chief there at Chester Fire, and he's also acting as the general manager these days there, since they let their general manager go. Basically, he tells me that as far as staffing goes, that he believes he has local staff that he can supply and have at the ready when needed. You know, this has been a problem for ever since I took over this spot 7 years ago, this transportation problem. Brian seems more than willing to help, though, and he says plenty of locals that he can get to do the job. They also have an ambulance at the ready, and it's a 4x4 ambulance. So in the wintertime, which is our greatest need to get ground transportation in the winter, is where we need it the most. And he did tell me that their biggest concern, because you know the ambulance portion of our budget there at the public utility district is in the red, and they're basically broke. The fire side, they make money, but the ambulance does not. And whenever they have to ground transport anybody off of the mountain, they end up taking a big loss on it. So he did mention that he could, you know, get staff members for this ambulance, but that they would probably ask for some sort of funding from the hospital to help with that. It's basically what he told me.
Royce, this is Jerry.
Yeah.
Don't people charge insurance when the ambulance is involved?
Yes, they do. Most of these are Medi-Cal patients, and I just believe that they're average, the average of what they recoup from when they take somebody off the mountain is not enough to cover their cost, is basically what he's telling me.
Royce, could I just interrupt for a second?
Sure.
This is Dr. Walls. Also, an awful lot of the cost is paying these people to be available on call. And during that time, they're not generating revenue.
Correct. I believe that from what Brian told me, that they would incur the cost of having these additional staff members on call. It's just that the biggest portion of their loss is when they actually have to transfer somebody off of the mountain, and then they incur that loss when they're actually on the clock, you know, not just on call, because it's a different pay scale when somebody's on call as opposed to when they come and work.
And Royce, did they throw out any numbers with this at all?
No, he didn't.
Steve,
Sorry. There was an incident, and I'm just going to throw this out there for comparison. We had a patient that needed to be ground transported from our hospital to Renown the other day, and we got SIMSA to do it. I'm pretty tight with Trent, who runs their ground transportation and their flight crews, and I asked him what his loss was. Just flat. Give me a flat rate as what his loss was for that particular transport, and he came up with $2,200.
so Steve, I don't know whether this is at all possible or not, but I'm wondering whether, you know, if the issue is, you know, how much the reimbursement is, I wonder if under our umbrella as a critical access hospital, if we receive a higher reimbursement rate for that, if maybe we could use a vehicle for that. I don't know. I'm just throwing that out there as an idea.
The short answer on that one is that all we would do is we'd start taking the beating instead of them, and unless all of the ambulance services would consolidate together. If there's only one provider and it's based out of a critical access hospital, we would get significantly enhanced reimbursement.
It would have to be.
Yeah, so we'll start the dialogue with them, and I'm reasonable. Actually, the transfer that Royce was talking about was the transfer of a COVID patient, so that was, that's no time to be pinching pennies and arguing over money. That patient needed to go get appropriate care, not sit and wait for an ambulance. So anyway, we will move forward with discussions, but we just wanted to give you an update.
Okay, thank you. Steve,
Yep.
anything else?
Thank you, Royce.
Thank you.
Steve, anything else?
No, I just put the budget on there because I'm going to start working on a budget for this current year. I think we have a sense of revenue and we have a sense of expense, and I think we could put something together that you guys can look at. It'll kind of mirror the projection methodology, but with a little more realistic numbers.
Okay.
So look forward to that in August.
Okay, thank you, Steve. I guess we're moving on to item number 13, the departmental issues and reports. We've had several reports submitted, so what I do, I'll just walk through these one at a time, see if there's any questions or if staff would like to add anything to the report. So the quality care, patient care coordination, patient safety report submitted by Casey. Review that, any comments or questions?
I just wanted to comment, I appreciate the thoroughness of it, of several of these reports, as a matter of fact. So thank you to staff and managers.
Anything staff would like to add to the report? All right, I'll move on to the compliance report from Sadie. Report was submitted. Comments, questions? Anything additional from staff? Okay. And Karen with the acute emergency department report, and says, see the COVID-19 update. Karen, you spoke a little bit about the COVID situation, and Steve did as well. Anything to add here?
I just wanted to say that we've gotten a lot of positive comments from the community about our drive-through testing.
Right.
So that is something that we're going to continue to do if possible, at least for the near future.
Karen, I'm just wondering if you could speak to one thing. You and I briefly talked about it. It's the idea of reporting for compliance in some of our businesses, and we see people in the community not adhering to appropriate protocols. Is there a reporting protocol for this that you're aware of?
Not that I'm aware of, Ken. I did talk to the health department to ask them if they were going around and doing some spot checking on these, specifically the restaurants, not masking up. They were all supposed to have a plan. And I think that they have just in the last couple of weeks got around to going and checking on these places. But now that they've been shut down again, it's a whole different ballgame. It's only outdoor, it's supposed to be outdoor dining. So I think they've kind of changed over to what they're doing right now. But every single business was supposed to have a plan of what they were going to do. If they're going to mask up, if they're going to keep people from coming in without their masks. Now, whether they're policing that, I don't know if they have adequate staff to police every single business.
Yeah. Well, I'm happy to report that I went to Drake's Bed last night and everyone there was wearing a mask and tables were separated by quite a distance. So I felt pretty secure in the process.
Yeah, great. That's
All right.
great.
Okay. Ann Holt, telemedicine clinic questions. Ann, anything if you're on the line, anything to add? Okay, I guess not. And then we have TK with the IT and the clinical informatics report. There was no report submitted, but she does make a comment that Evident and several server updates were installed without incident. So, comments, questions? No? Okay, and then human resources. Had a chance to look at that. Do you have any questions? Jim, any questions?
No, I'm good.
Okay, thank you so much. All right, let's move on to item number 14, which is items for next month's agenda. Anything new beyond our standard discussion here? Steve, anything you need added to the agenda?
Nope.
That said, what time do we have right now? I'm showing 4:40. Why don't we take a 5-minute break and come back at 4:45, and then I'll give TK a chance to assure that we have a confidential closed session starting at 4:45. Okay?
Hey, Ken, this is Steve. I just got an email from Judith Cragen. She is standing by, so whoever needs to contact her or whatever, she might already have the information, but she's ready to go.
He's ready to go. Well, we're going to take a 5-minute stretch here just to give TK an opportunity to make sure we're truly in a closed session. And then we'd like to start off, I guess, with Judith Cragen.
Ken,
Okay.
are you having any other folks joining you in closed session today?
Yes, we will. We'll actually probably have Steve join us at some point for some of these items. And perhaps Jim. Let me just hang on just a second. Closed session items.
Yeah, I wanted to go over the negotiations with the union with you.
Yeah, so we will, let's get Judith that item taken care of first, and then we can take separately items with Steve and Jim, okay?
Okay, I just wanted to announce that these participants will be in the waiting room and that we will bring them in one at a time as you're ready for them.
Okay, thank you so much.
So if they could stay connected and stay on hold and in the waiting room, I will bring them back in.
That's perfect. So we took a few minutes to do that. Let's make it 11:46, okay? All right, thank you.
Okay, we're live.
Okay, thank you. So the board has concluded its closed session, and we will now resume our open session. There's no reportable action from the closed session. Administration has been authorize simply to continue labor negotiations with the employees union. So our next meeting, regular meeting is scheduled for August 27th at 3 p.m. I guess at this point, we're still scheduled to be in a Zoom mode. If that changes, we will certainly let people know. So thank you all. Appreciate your input and talk soon. Okay. Bye all.
Bye.